Good afternoon, students. Department of Outpatient Therapy. My today's topic is differential diagnosis of jaundice and hepatomegaly, outpatient aspects of diagnosis and treatment of chronic hepatitis and liver cirrhosis. Jaundice is usually detectable clinically when the plasma bilirubin ascends 40 micromole per liter. The causes of jaundice overlap with the causes of abnormal liver function test described above. In a patient with jaundice, it is useful to consider where the causes might be prehepatic, hepatic, or post-hepatic, and there are often important clues of the history. Clinical laboratory disorders of the liver. These laboratory disorders of liver damage. Cytolytic syndrome, the syndrome of mesenchymal inflammation, cholestatic jaundice syndrome, and syndrome of hepatic cell deficiency. Cytolytic syndrome. Clinically, jaundice, hepatolgia, biochemical markers are increased in IST, ALT, LDLS, LDH, hyperbilirubinemia, with increased primary detect fraction, increased serum concentration of iron and vitamin B12. The syndrome of mesenchymal inflammation, clinically demonstrated by fever, hepatolgia, arthalgia, erythema nodulus, polycirrhosis, epididymitis. Biochemical markers increased in hemoglobin G, M, A, globulin changed in the amount and ratio of T lymphocytes. Cholestatic jaundice syndrome, persistent cirrhosis, xanthelasma, and osteoporosis and bone pain. Biochemical markers of cholestasis increase the level of bilirubin, cholesterol, lipoprotein, bile acids, alkaline phosphatase, 5-nucleotidase, gamma-glutamin transpeptidase. The syndrome of hepatic cell deficiency manifests under investigation syndromes and dyspepsia. High-activity jaundice, hepatomegaly, the presence of spider veins, gynecomastia, alopecia, due to violation of estrogen inactivation. Biochemical markers of the syndrome are reduction of serum albumin, clotting factors 2, 5, 7, prothrombin, cholesterol, decreased presence of antipyrine, increase in number of nitrogenous base. These are clinical disorders of liver dysfunction. Edematous ascitic syndrome, associated with hypoalbuminemia, secondary hyperaldosteronism, portal hypertension. Portal hypertension is manifest ascites, varicose veins of the anterior abdominal wall medulla, esophagus, stomach, and upper third of the rectum. Anemic and hemorrhagic syndrome associated with bleeding from varicose veins due to symptom of portal hypertension, with bleeding from upper intestinal tract, when Zollinger-Ellison, and hemorrhagic gastritis. Add insufficiency of blood coagulation factor with iron and B12 deficiency, anemia, hypoalbuminemia, with increased degradation of red blood cells in the spleen when splenomegaly. Ethanol has the toxic effect of the bone marrow. Splenomegaly reasons. And almost always secondary to other diseases, which allowed as well as possible ways to classify them. Myeloproliferative and liver-proliferative disease, storage diseases, culture disease, connective tissue disorders are most common causes of splenomegaly. In temperate climate, all infectious disease such as malaria, predominant is tropics. The cause is pronounced splenomegaly, spleen below 8 cm below the costal arch, and usually the following diseases: chronic lymphocytic leukemia, non-Hodgkin's lymphoma, chronic myeloid leukemia, polycythemia, myelofibrosis with myeloid metaplasia, and hairy cell leukemia. Acute infections, mononucleosis, infection hepatitis, cervicobacterial endocarditis, cytochrosis. Chronic infections, miliary tuberculosis, malaria, brucellosis, Indian leishmaniasis, syphilis, sarcoidosis, amyloidosis, connective tissue disease, Ehlers-Danlos syndrome, myeloproliferative and lymphoproliferative disease. Normally, up to 3% of people have palpable spleen. Hypersplenism is a syndrome characterized by a decrease of the number of blood cells, leukopenia, thrombocytopenia, anemia. In a patient with liver disease, manifest by hepatosplenomegaly. Clinical examination of the abdomen for liver and bladder disease. If we can see Hence, we can find pulmonary erythema, climb between contraction, leukonia, bruising, and flapping tremor. This patient has hepatic encephalopathy. Examination of the face, we can see xanthelasma and jaundice sclera in a patient with chronic cholecystosis. Causal rings in Wilson disease. Our examination of the chest, it can be loss of body hair, gynecomastia, spina A.V. Abdomen inspection, we can find scrubs, distension, veins, testicular atrophy, dilated abdomen wall maze, medusa. Abdomen and palpation and percussion, hepatomegaly, splenomegaly, ascites, palpable gallbladder, hepatic, road, and tumor. Causes of change in liver size. Large spleen, hepatomegaly. It can be liver metastasis, multiply or large hepatic cysts. Cirrhosis, its early stage, non-alcoholic fatty liver disease, alcohol hematochromatoses, hepatic vein or flow obstruction, infiltration amyloid, and small lesions will be last stage late of cirrhosis. Chronic liver disease screen. Hepatitis B surface antigen, hepatitis C antibody, liver antibodies, antinuclear antibodies, smooth muscle antibodies, antimitochondrial antibody, immunoglobulins, ferritin, alpha-1 antitrypsin, ceruloplasmin. We're talking about hepatic and cholestatic obstructive liver function test. We should see AST-ALT function, hemoglobin transpeptidase, alkaline phosphatase. For biliary obstruction, it will be characteristic increase of alkaline phosphatase more than AST-ALT or transpeptidase. For hepatitis, a characteristic increase of ALT and AST. For alcohol enzyme drugs, it will be characteristic of increased gamma-globin transpeptidase more than others. How to identify the causes of liver function test abnormality? What's the reasons? It can be alcoholic liver disease, non-alcoholic fatty liver disease, chronic hepatitis B, chronic hepatitis C, primary biliary cholangitis, primary sclerosing cholangitis, autoimmune hepatitis, hemochromatosis, Wilson disease, alpha-1 antitrypsin, drug-induced liver disease, and celiac disease. And in this table, we can see what characteristics for clinical clue, initial test, and additional test. For example, for non-alcoholic fatty liver disease, it should be metabolic syndrome, central obesity, diabetes, hypertension, liver function test. We can examine and liver biopsy. For example, primary biliary cholangitis, in clinical incubation, raised alkaline phosphatase, and initial test we can find antimitochondrial antibodies, and traditional test it's liver biopsy. Wilson disease, neurological signs. How can we find initial test? Ceruloplasmin, additional test 24 hours urinary recovery. For celiac disease, molar absorption will be in clinic initial test, tissue transglutaminase, and additional test, duodenal biopsy. And for others, you can see in this table. Key history points in a patient with jaundice. Symptoms may be absent and abnormal liver function test detected. So, itching, present jaundice. Abnormal pain, suggested stones, fatigue, weight loss, risk for chronic liver disease and malignancy, dark urine and pale stool, fever, rigors, dry mouth, present drug history, others, exposed to intravenous drug or blood transmissions, travel history and country of birth, metabolic syndrome, increased body mass index, types 2 diabetes or hypertension, autoimmune disease history, alcohol history, inflammatory bowel disease, family history of liver disease, autoimmune disease, or the metabolic syndrome. Causes of cholestatic jaundice. It can be extrahepatic and intrahepatic. Intrahepatic. Primary biliary cholangitis. primary sclerosing cholangitis, alcohol, drugs, hepatic infiltration, lymphoma, granuloma, amyloid metastasis, cyst fibrosis, severe bacterial infections, pregnancy, inherited cholestatic liver disease, and benign recurrent intrahepatic cholestasis, and chronic right heart failure, extrahepatic carcinoma. It can be ampullary pancreatic bile duct cholangiocarcinoma, liver metastasis, cholelithiasis, traumatic biliary structure, parasitic infections, chronic pancreatitis. This investigation of jaundice is, of course, we should ask history and examination of the patient, serological test, liver test, liver ultrasound, and urine for bilirubin. And if it can be pre-hepatic, as we said, hepatic or post-hepatic obstructive jaundice. For pre-hepatic conjugated or unconjugated bilirubin, it can be for unconjugated bilirubin, it can be Gilbert syndrome, or it can be Davin-Jones syndrome. It's a very rare reason. Or can be hemolysis. As for hepatocellular jaundice, clotting, hepatitis, immunoglobulins, autoantibodies, herpestatus, arestatus, post-static jaundice, cholangiography. Causes of viral hepatitis: common is hepatitis A, B, together with or without, hepatitis D, hepatitis C, hepatitis E, less common cytomegalovirus, Epstein-Barr virus, rare herpes simplex, yellow fever. Cirrhosis. Cirrhosis is characterized by diffuse hepatic fibrosis and nodule formation. It can occur at any age, has significant mortality, and is an important cause of premature death. It is the most common cause of portal hypertension and its complications. The most common causes are chronic viral hepatitis, prolonged excessive alcohol consumption, and non-alcoholic fatty liver disease. But any conditions leads to persistent or recurrent hepatocyte death may lead to cirrhosis. Cirrhosis may also occur in prolonged biliary damage or obstruction, as it found in primary biliary cholangitis, primary sclerosing cholangitis, and post-surgical biliary structures. Persistent blockage of venous return from the liver, such as found in sinusoidal obstruction syndrome and Budd-Chiari syndrome, can also result in cirrhosis. Clinical features of hepatitis, cirrhosis. Hepatomegaly. Also, patient may also be small in the last stages. Jaundice, ascites, circulatory changes, spinal cholangioectasia, palmar-erythema, cyanosis, endocrine changes, loss of libido, hair loss. For men, gynecomastia, testicular atrophy, impotence. For women, breast atrophy, irregular menses, amenorrhea. Hemorrhagic encephalopathy, prosthesis, purpura, epistasis. Portal hypertension, splenomegaly, collateral veins, peripheral bleeding, hepatic or systemic encephalopathy. Other features: augmentation, digital climate, DPA transcontracture. Features of chronic liver failure: worsen systemic liver function, prolonged prothrombin time, low albumin, jaundice, portal hypertension, peripheral bleeding, hepatic encephalopathy, ascites, spontaneous bacterial peritonitis, hepatorenal failure. Child-Pugh classification of prognosis in cirrhosis. It include encephalopathy, bilirubin level, albumin, prothrombin time, and ascites. You see that 3 stages A, B, and C. It's according to scores. It's less than 7 in child A is from 7 to 9 in child B, more than 9 child C. It says that encephalopathy for first it's none, for second it's mild, and for third it's marked. It's a bilirubin. For primary biliary cholangitis sclerosis, it's less than 68. In a mild stage B, 68 to 170, and in the third it's 170. And other causes is cirrhosis, bilirubin. First, it's less than 34. For second, it's from 32 to 50. And for third, it's more than 50. Albumin level. And for first, it's more than 35. For second, less than 35. For second, 28 to 35. And for third, it's less than 28. Proton beam time less than 4 for first, for second from 2 to 6, and for third more than 6. Mastitis for first it's known, for second mild, and for third marked. How to assess clinical grade of hepatic encephalopathy? Clinical grade. It's 4 grades of hepatic encephalopathy. First grade, it's poor concentration, slurred speech, slow mentation, disordered sleep rhythm. For second grade, drowsy but irreversible, occasionally aggressive behavior, lethargic. For third grade, marked delirium, grossly sleepy but response to pain and voice, gross disorientation. Grade 4, unresponsible to voice, may or may not respond to painful stimuli, unconsciousness. Complication of portal hypertension, peripheral bleeding, esophageal, gastric, and aspria. Congestive gastropathy, hypersplenism, ascites, iron deficiency anemia, renal failure, hepatic encephalopathy. Liver cirrhosis treatment. Patients should avoid alcohol, smoking, elimination of the other or drugs with toxic effects on the liver as side effects. Factors provoking the occurrence and progressive of hepatic encephalopathy and gastrointestinal tract, gastrointestinal bleed infections, tranquilizers, NSAIDs, aspirin, inhibited cinemas, antibiotics such as macrolides, tetracycline, sulfonylureas. Antiretroviral drugs, cytostatics, methotrexate, anticoagulant syndrome. Ascites treatment. Use spironolactone is a first-line drug because it's a powerful aldosterone antagonism. Some patients answer while diuretics such as furosemide, but then can lead to fluid and electrolyte disbalance and renal dysfunction. So first-line treatment of refractory ascites in large volume is parasitosis. Antibacterial therapy of spontaneous bacterial peritonitis includes to use the cefotaxime 2 venously every 8 hours, or it can be amoxicillin with clavulanic acid. Prevent of the first episode of esophageal or gastric varicose bleeding, not selective beta blockers. A target decrease in heart rate by 25% or to 55 beats per minute. Propranolol or carvedilol. Esophageal endoscopic ligation with intolerance of to beta blockers and varicose veins to the vagus second and third degrees. Lactulose is a gold standard is a treatment of hepatic encephalopathy. It produces an osmotic laxative effect, reducing pH of the colon content, temporarily limited colonic ammonia absorption, and promotes the incorporation of nitrogen into bacteria. Infliximab is a well-tolerated, non-absorbed antibiotic that by reduction in bacterial content is a bowel and has been shown to be effective. Ultradesoxycholic acid, ademetionine. It can be orally or intravenously. Liver transplantation is the only radical treatment for patients with end-stage chronic diffuse liver disease. Thanks for your attention.